have to treat and take care compared to the other acute kidney injury, then other causes, then acute kidney injury due to pregnancy is very important, and we have to manage very aggressively. So before going in details, let us give some brief introduction. The acute kidney injury is defined by the apparent loss of the kidney function. You know, any kind of loss of the kidney function may be minor, may be moderate. If it is required the renal replacement therapy, sometimes it may not require the renal replacement therapy. That means dialysis. Acute kidney injury in pregnancy is a public problem, and we are facing all the problem right now. And it remains the leading cause of maternal and fetal morbidity and mortality. During the pregnancy, acute kidney injury can be due to any of the same disorder that affect the general population, such as prerenal, intrarenal, and postrenal. That is, as we know, the common causes of acute kidney injury, some of the factors before the kidney, some of the factors that are related to the within the kidney, and some of the factors outside the kidney, that is obstructive. If you see the epidemiology of acute kidney injury, virtually it is almost negligible in developed country. That is, acute kidney injury pregnancy is uncommon in developed country. It is the problem of the developing and underdeveloped country. Most reviews estimate that the countries with adequate antenatal care, only approximately 20,000 pregnancies are affected by acute kidney injury, severe enough to require the renal replacement therapy. And many of the cases that are minor acute kidney injury that doesn't require the renal replacement therapy. Nowadays in our country, most of the pregnancies are booked. That means they are under regular checkup of the antenatal care. But fortunately or unfortunately, the obstetrician, with due respect, they advise the protocol of the therapy and advise the investigation that are commonly required. But I haven't seen, I don't know if the practice or not, they never ask for the renal function at the first visit of the antenatal care. Do we? Yes. This is the basic and the story what we should do right now. That means we should know because in hemodynamics, a lot of changes occur during the pregnancy. I am coming to that. We should ask for the baseline renal function. Because we don't have the baseline serum creatinine function, we often miss the minor elevation that may be the acute kidney. So next time we should ask that the other investigation, the baseline serum creatinine also, is the very cheap investigation that should be documented and the antenatal card. The incidence may be considerably higher in countries where antenatal care is less available and where illegal abortion are performed. Nowadays, these incidents are coming drastically in our country also. And if you see down the 10 years of the maternal mortality rate, it is declining considerably in our country because of the most of the institutional delivery. So now a new term is coming, the acute kidney injury, that is called the PRAKI, P-R-K-I. That means pregnancy-related acute kidney. This is a new terminology in the world, or it is now gaining popularity. Pregnancy-related acute kidney injury is a global health public problem, and it significantly affects the fetal-maternal outcome. The overall incidence of PRAKI has reduced with development of healthcare in both developing and developed countries. However, there has been a recent increase in developed countries due to the hypertension and thrombotic disorder. In our countries, the early marriage is a rule. Nowadays it is getting some correction, but in developed country, the late marriage is nowadays a fashion. So in the late, when the woman is getting married and conceived in the late, there is a lots of comorbid factors. That is non-communicable factors like diabetes, hypertension, dyslipidemia. That affect the pregnancy and causes the acute kidney injury in the pregnancy. That is their problem. But in our problem, that means something is different. But both in the cases, the acute kidney injury incidence is. India has witnessed a significant decline in the PRAKI incidence over the last few decades, as you know, largely due to the decline in the rates of the septic abortion. Now it is very less. Healthcare facilities to manage pregnancy-related complications such as the hemorrhage. Hemorrhage in pregnancy, now it is well managed. There are some government protocol which is running in our country that also reduces the pregnancy-related acute kidney injury, like Janani Surakha Yojana and Pradhan Mantri Surakshit Matritva Abhigyan. Because of the financial help, patients are now coming more and more for institutional delivery rather than the home delivery, which was the earlier practice even in the 15 or 20 years back, and that reduces the acute kidney injury. The diagnosis of the PRAKI can be challenging in part due to the lack of uniform diagnostic criteria and lack of availability of the baseline serum creatinine at the time of the first antenatal visit. and the multitude factor of that can cause the acute kidney. The long-term impact of the PRAKI, that is acute kidney injury in pregnancy, risks the chronic hypertension, chronic kidney disease and cardiovascular disease that mandates appropriate attention and close follow-up. Once the patient develops acute kidney injury in one pregnancy, if that lady want to conceive subsequently, there is chance of the acute kidney disease manifold. And the subsequently, every patient don't require the renal replacement therapy, there is a chance of development of the chronic kidney disease also higher and chance of hypertension is also higher. Let us come to see the maternal and fetal outcome with the pregnancy. Pregnancy-related acute kidney injury has shown to be associated with 14-fold higher likelihood of the in-patient mortality. As we can see, the healthy person, if develop the acute kidney injury after or during pregnancy, there is a higher mortality and 10-fold higher risk of the cardiovascular events, including the higher healthcare utilization and longer hospital stay. All of you, those working in the CCU know, once the patient comes from the obstetrician for the acute kidney, it takes longer time for discharge than the other patient, because it takes time to recover. Because whatever changes that occur during the pregnancy, it takes minimum 6 weeks to return back to the preconceived level. That's why the recovery is unpredictable. Pregnancy-related acute kidney injury increases the risk of the chronic kidney disease subsequently and the kidney failure. That is a major public health in the near future. The risk of the adverse fetal outcome of preterm birth, low birth weight, and the neonatal intensive care unit admission is increases, and perinatal mortality is higher with pregnancy-related acute kidney injury. History of recovered acute kidney injury despite return to the normal kidney function before pregnancy also increase the risk of the preeclampsia, fetal growth restriction. That means the lady who developed the acute kidney injury, whatever may be, if she wants to conceive subsequently, there is a higher chance of development of preeclampsia and eclampsia and pregnancy-related complications in subsequent pregnancies. These are some physiological changes. Why this acute kidney injury is much higher in the pregnancy? Because of the alteration of the physiology. Although pregnancy is a normal procedure, but a lot of changes occur during the pregnancy in terms of the physiological. The most organ system is pregnant. I will not discuss all the organic changes that occur during the pregnancy. I will concentrate whatever changes occur on the kidney only. The most organ system in the pregnant female undergo changes in order to accommodate the growing fetoplacental unit. That means it is a new guest. The body changes accordingly to welcome that guest. There are considerable changes that occur in the urinated system. Both kidneys, ureters increases size to 1.5 centimeter accompanied with dilatation of all the urinary tract and renal calyces. The dilatation of the urinary system is due to the hormonal effect like progesterone, external compression by the gravid uterus with the progression of the pregnancy, and the morphology changes of the uterine wall also. Progesterone also increases the ureteral peristalsis, contraction and the tone. Because of the laxity, there is a higher chance of the infection. The decreased bladder tone and the bladder hyperemia and the edema potentiate the symptomatic bacteria, the chance of the asymptomatic bacteria. This is the only one condition where asymptomatic bacteria is treated. That means pregnancy with asymptomatic bacteria, you have to treat it. While bladder flaccidity and affect the vesicular reflux, that causes the vesicular reflux and urinary tract infection. If you see the result that can occur during the pregnancy, mostly the increased risk of the urinary stasis, because whatever urine is forming, it is not coming smoothly like the normal, because the laxity of the walls, because of the low peristaltic movement and the opening of all the that is the sphincter. There is a higher incidence of the urinary tract infection, pyelonephritis. The systemic vasodilated state, you know the pregnancy is a systemic vasodilated state, and increases renal perfusion and increased glomerular filtration rate. How much I am coming? Due to the rise in the glomerular filtration rate, hyperuricemia, hypouricemia, and increased urine protein excretion occur. More vasodilatation, more glomerular filtration, protein are excreting, there is a chance of the hyperuricemia also, and the uric acid also eliminated very large amount. Systemic vasodilatation to the stimulation of the antidiuretic hormone ADH secretion from the brain increases, and that causes the increased thirst. There is a patient try to take more and more water, and decreases the plasma osmolality. If you see the osmolality, it is, and the serum sodium level is also decreases. That in in turn increases the thrust and patient takes more and more water. That increases the intravascular volume dilatation and chance of hypertension is much more. Is it visible? If you see the anatomical structural changes that occur, the size of the kidneys are increases, both the kidney sizes are increases, and there are pelvic axial dilatation. Right is more than the left, and only the obstetricians can say why this right kidney is more dilated than the left kidney because of the vertex and gravidiuterus fetus presentation. Most of the presentation, as you know, LOA, that is the left occipital anterior, they obstruct the right kidney and cause a dilatation. And the hydronephrotic changes also occur more in the right kidney than the left. There is increased glomerular filtration rate, and there is both afferent and efferent arterial dilatation of both the kidneys. And decreased renovascular resistance, that means the blood freely flow to the glomerulus. There is an increased renal hemodynamic changes, and if you see the renal plasma blood flow increases 50 to 85%. That is a huge. Normally our kidney get 25% of the cardiac output, but during the pregnancy, the 50%, the huge amount of blood goes to the kidney because of the increased vascularity and the increased renal plasma flow. And the ejection, the filtration fraction is decreases. That means whatever blood is coming to the glomerulus, that is not being totally filtered, and urine production is not increased. Rather, it passes to the systemic circulation that increases as the systemic volume. If you see, the GFR increases by 50% during pregnancy, and the decreased plasma creatinine level. That whatever creatinine you are seeing, even the 0.5 milligram creatinine is a upper normal limit in pregnancy. So if you see a patient whose serum creatinine baseline 0.5 and it goes to the 0.9, as per all the laboratory reports, you will get within normal limit, but it is higher than that patient. So baseline level is very important because the plasma creatinine level is decreases. It is dilution now, not by decreased production. It is by dilution because of the increased volume that accumulates the pregnant lady. And increased proteinuria, but it is within 300 milligram, not beyond that. If it is there, then we have to think of the preeclampsia. So some changes that occur in the tubule of the glomerulus are the decreased osmolality in the renin-angiotensin activating system, increased water retention, decreased osmolality, and there is an increased calciuria, increased glycosuria, that even more glucose is eliminated during pregnancy, and decreased serum levels of the uric acid, and the increased bicarbonate deuteria. That means bicarbonate loss is there during the pregnancy. So some kind of metabolic acidosis will be there during pregnancy. So normal bicarbonate level, if you think 24 in this pregnant lady, it will be 22 plus minus. That means always some acidotic changes are there during pregnancy. So because of that, patient may hyperventilate because of refractive correction or corrective respiratory alkalosis. So this pregnant lady hyperventilate. Some endocrinal changes is there, that is increased RAS activity, that is increased renin activation, receptor changes are there, I will come. So these are the renal adaptation of kidney during the pregnancy that occur in all the patients. So substantial structural, functional, and hemodynamic changes occur during normal pregnancy, not in abnormal. And understanding these changes is crucial for recognizing the normal values and abnormal mechanisms. So in your report, you will never see what is the normal value, whatever laboratory report give, that is for pregnancy or for the renal impairment. All the reports are assumed to the normal persons. So these are important to identify the disorder during the pregnancy. Kidney size raises by typically 30%. Whatever the kidney size, near about 1 to 1.5 centimeter increase in the length. Overall volume is also increases. The early pregnancy renal plasma flow and exceed the glomerular filtration rate, leading to the lower filtration fraction compared to the non-pregnant individual. All renal changes normalize 4 to 6 weeks after delivery. That means because during period, if the patient develops some points of abnormality, it takes this period to become normalized. So this is physiological changes to the all organ. I am not going details. I will concentrate only to the nephrology only. So it is not clear that the consensus criteria for AKI are useful in pregnancy because there is no universal criteria what should be the. But if you have the baseline serum creatinine, there is 0.3 milligram rise, you can diagnose the acute kidney injury. So whatever if your baseline is 0.4 milligram, if it is goes 0.7 milligram, then you can assume the patient is developed the acute kidney injury. This is because during pregnancy, glomerular filtration rate increases significantly, resulting in the lower baseline serum creatinine compared with the similarly healthy and non-pregnant individuals. And most obstetricians do not routinely check the serum creatinine either prior or early in the pregnancy. That is our drawback. We should do it in the very early to all the patients. Thus, increasingly normal serum creatinine level, which is normal 0.7 to 0.9 milligram per dl, may represent significant increases, and often we ignore that patient is not developing any kind of the renal abnormality. So these are the RAS activation is also exerted during the pregnancy. This is basically of the placenta and the ovary. You know the placenta during pregnancy, it increases the production of the renin-angiotensin system, and renin-angiotensin system renin is more production is increases during placenta and the ovary, which in turn they convert the angiotensin to angiotensinogen. Then for the lung it is converted angiotensin 1 to angiotensin 2. All this eventually causes the decreased sodium level, decreased osmolality, which in turn causes the fluid retention and the more and thrust. Patient want to take more and more fluid. So there is an sodium and water hemostasis abnormalities there. All these factors, the natriuretic factor, antinatriuretic factor, increased plasma volume, reset osmoreceptor. In the brain, there is a reset of the osmoreceptor in the brain also. Brain sensitized that whenever they are lower level, it increases production of the ADH. More and more ADH production occur during the pregnancy. That increases the volume load and hyponatremia and volume overload. So if you see in the pregnancy, the upper one is the effective renal plasma flow and the lower is the GFR. The more blood going to the kidney, but ultimately the nodes are not filtered, lower amount are filtered, all are bypassed to the systemic circulation. And these changes occur around 26 weeks of pregnancy and decreases near to the gestational period. So these are the changes, that systemic changes and the renal hemodynamic changes that I have discovered. There is a 50 to 85% increase in renal blood flow and 50% increase in GFR. And there is a structural change of the pelvic calcium system, tubular, some changes are there. In the hypothalamus, there is a decreased threshold for the vasopressin release, which increases the ADH secretion. So if you see the serum creatinine changes in the normal person and the pregnant lady, in serum creatinine, which is 0.5 milligrams, should be considered as a normal if there is no renal abnormality, because it is mostly decreases during pregnancy. Blood urea nitrogen should be 9 is the normal upper limit. Creatinine clearance is increases 25%. So if you get more and more urine, you should not be happy because it is normal. Uric acid level decreases during the pregnancy and normal value is 2 to 3. So if the uric acid level 6 during pregnancy, it is some alarming sign that something going wrong. And urinary protein excretion maximum, it is less than 300. In pregnancy, some amount of protein excretion increases, but that should not cross the 300 milligram in 24 hours. Sodium level is sodium retention is there. Normally 900 to 950 milliequivalent sodium retention is there. Osmolality decreases. You see it is 270, maybe the maximum osmolality during the pregnancy. PCO2 also between 27 to 32. And pH, it is little to the alkalosis because of the low bicarbonate level, 7.4 to 7.5. And bicarbonate level, it is 18 to 20, which is below the normal because of the bicarbonate urea. And urinary glucose, it is also maybe there during the pregnancy, depending upon the glucose stat load of the pregnancy. Some cardiovascular changes that occur that also adversely affect to the kidney also. During the normal pregnancy, systemic vascular resistance is markedly reduced, whereas the total blood volume and the cardiac output increases by 50% also. So both increased plasma volume and the lesser degree the red blood cell volume contribute to the expansion of the total blood volume is increased. The gradual increase the plasma volume is achieved by the net retention of the sodium, which is 900 to 950 milliequivalent during a pregnancy. And the net sodium reabsorption occur at the level of the renal tubules, as we know, the juxtaglomerular apparatus. And the physiologic decrease in the plasma osmolarity also occur in the early pregnancy, reaching to the nadir at the approximately 10 weeks and then remaining the stable for the remaining period. So if you consider the fetus, what happened during these changes, the normal physiologic changes of the pregnancy occur in the accommodate to the growing placental unit. As we know, with maternal disease, it is imperative to have an underlying of the effect of the pregnancy of the particular disease condition, as well as the effect of the such disease process on the progression of the pregnancy and the implication of the fetal development well-being. The important consideration includes the viability of the fetus, gestational age, complication of prematurity, and optimization of the fetal status. So most important, how much the uteroplacental hemodynamic and fetal oxygen delivery changes during the pregnancy. So what are the common causes or etiology of the acute kidney injury in pregnancy? The most common cause of the acute kidney injury pregnancy is the depend on the trimester. The factor varies, which some are important for the first trimester, some are very important for the second trimester, and some are particularly important for the third trimester. So at which trimester you are dealing, the depend and cause are also important. In the first trimester, that means if you consider the early pregnancy, that is less than 20 weeks of gestation, that is we can consider as an early pregnancy. The prerenal disease due to the hyperemesis gravidarum, which is also less nowadays, this is the most common cause. Acute tubular necrosis resulting from the septic abortion, which is also practice is now declining. An acute kidney injury with either viral or bacterial infection and or sepsis, that means urinary infection or systemic infection, that is a major cause of the acute kidney injury in early pregnancy. So, acute kidney injury etiology in the pregnancy, in the prerenal, some are the, I have earlier told that some are prerenal causes, some are intrarenal causes, some are the postrenal causes. If you consider the prerenal causes, mostly the hemorrhage, maybe the mesoplacental hemorrhage or abruptio placentae, hyperemesis gravidarum, congestive heart failure, and sepsis. These causes are prerenal causes of the acute kidney injury during pregnancy. The intrarenal causes are the thrombotic microangiopathy, I will come in details, preeclampsia with or without HELLP syndrome, acute fatty liver of pregnancy, glomerulonephritis. You know, pregnancy is an immunocompromised state. If the patient had a history of the glomerular disease or some immunological disease, particularly the SLE or other glomerular disease, they all get flare up during the pregnancy. Because pregnancy is the immunocompromised state, these diseases are flare up. And the concurrent medication, these are the major factor of the intrarenal causes of the acute kidney injury in pregnancy. And postrenal causes are mostly obstetrical, that is, we see the ureters are somehow, it is compressed or tight, that can cause the acute kidney injury in pregnancy. So what I was talking, you have to think of which trimester patient you are dealing. It is the first trimester, second trimester, third trimester, and after the delivery, that is the postpartum period. So in the first trimester, hyperemesis gravidarum and septic abortion are the only two major causes of the acute kidney injury. The major problem we see and face in the obstetrical and the critical care unit is the third trimester and peripartum period. That is the major burden in our patients. There may be obstruction of the there may be obstruction, acute fatty liver of pregnancy, placental abruption or hemorrhage, preeclampsia, eclampsia or HELLP syndrome, thrombotic thrombocytopenic purpura, atypical hemolytic uremic syndrome. These are the major causes of third trimester or late pregnancy acute cause of the acute kidney injury. And after the delivery, what we know, there is some hemodynamic changes that occur in the kidney. It takes time at least 6 weeks to recover. Without knowing, to relieve the pain, we give the analgesic, and mostly the combination analgesic. They are very much detrimental. They block the prostaglandin and prostacyclin in the afferent arteriole. What they cause is, they certainly cause a narrowing of the afferent arteriole and acute injury, kidney injury. So before prescribing analgesic in the immediate postpartum period, mostly the 6 weeks, don't use the combination analgesic, use the single analgesic that is very good and safe. They don't cause the acute injury. Because the NSAID and misuse of the NSAID is a very important cause of the postpartum acute kidney injury. Patient often asks for the pain relieving medicine and we give the combination analgesic. Either ibuprofen, paracetamol or various else combination are there. Don't use the combination. And you see the last two lines, the glomerulonephritis and the urinary tract infection and pyelonephritis. I have just told you that glomerulonephritis is for pregnancy is immunocompromised state. All the glomerular diseases flare up during the pregnancy, and they can cause the acute kidney injury. And the urinary tract infection, as you have by this time come to know, that there is a laxity and there is a chance of the retention of the urine. There is a more chance of the urethritis. There is lower urinary tract infection that goes to the kidneys, that causes the upper urinary tract infection and pyelonephritis. So this is the I will discuss one by one the how this helpful. So preeclampsia with or without the help, these are the problem of the late second trimester and the third trimester. This preeclampsia. So preeclampsia is the most common cause of the acute kidney injury during pregnancy before delivery. In our country also, preeclampsia, mind it. So preeclampsia refer to the new onset of the hypertension and either proteinuria or other signs of the systemic disease. What are the systemic disease? Including thrombocytopenia, elevated liver enzyme, acute kidney injury, pulmonary edema, cerebral and or visual disturbances. If it is organic involvement, that is called the severe preeclampsia. If it is not proteinuria or hypertension, proteinuria, then it is eclampsia. That usually occur after 20 weeks of gestation. So it is the problem of the after 20 weeks. So preeclampsia complete 3 to 5% of the all pregnancies. The risk is increased due among the hypertension, diabetes or CKD from the any other causes. If the before the conception patient is suffering from some degree of the renal impairment or pre-existing hypertension or some glomerular disease, there is a chance of the preeclampsia or severe preeclampsia much more higher than to the other patient. The most women with preeclampsia, GFR decreases on an average 30 to 40%, rapid decline, which result in only minor increase in the serum creatinine. So you may not get the rise of the serum creatinine, but if you calculate the GFR, there is a much decline in the GFR. Preeclampsia may occur with or without features of the HELLP syndrome. HELLP syndrome refer to the variant in which hemolysis, low platelet count, and elevated liver enzymes are present. So these are the two variants, as you know, preeclampsia with or without HELLP syndrome. If you want to categorize the HELLP syndrome, you have to show that hemolysis are there, low platelet count is there, and elevated liver enzyme is there to fulfill the criteria of the HELLP syndrome. So AKI is more common when the preeclampsia is accompanied with the feature of the HELLP syndrome. Alone, AKI is very uncommon or less common in acute kidney injury during pregnancy. But if HELLP syndrome is preeclampsia is accompanied with the HELLP syndrome, but in severe preeclampsia, there is a chance of the acute kidney injury is less. Some studies suggest that the acute kidney injury occurs 3 to 5% of the cases of the preeclampsia associated with the HELLP syndrome. But I was talking that acute kidney injury is much less common in patients with severe preeclampsia without feature of the HELLP syndrome. So acute kidney injury is more common in case of HELLP syndrome, preeclampsia with HELLP syndrome, but severe preeclampsia with HELLP syndrome AKI is less common. Severe preeclampsia is an indication for urgent delivery. As you know, you have to take out the product, then it can resolve all the issues. The renal and the external abnormalities are typically benign, begin to really resolve spontaneously within 2 to 3 days postpartum, and complete recovery of GFR occurs within 8 weeks of the postpartum. So if there is you are dealing the preeclampsia or severe preeclampsia, just take out the baby, considering the viability and take out the newborn care, the mother will be all right. The volume depletion can lead to the acute kidney injury causing the prerenal ischemia. As I just mentioned, in pregnancy, the most common cause of the volume depletion. That means in pregnancy, as we know, the volume is added because some factors are there where volume is depleted during the pregnancy. And the volume depletion of this magnitude is obstetric hemorrhage. That is, it may be revealed or it may be concealed, which can occur at any gestational age. So see, the common causes of obstetric hemorrhage, this is a topic of the obstetrician. You know that in ectopic pregnancy, in the first trimester is the most common cause of the hemorrhage that causes the volume depletion. Pregnancy that implant outside the uterus, it is called the ectopic pregnancy. The most surgical correction is the standard of therapy. And the induced or spontaneous abortion that can cause the volume depletion together with the sepsis Yes, persistent heavy bleeding is often due to the product of constitution are not properly removed. So what you can do, you can just DNC that will remove the product of constitution and will correct the volume depletion. Placental abruption or abruptio placentae, this is mostly seen in the second and third trimester. Sometimes it may be revealed or sometimes it may be concealed. The separation of the placenta from the uterine wall before the delivery of the fetus usually present as vaginal or bleeding and severe abdominal pain, uterine tenderness and contraction. And severe abruptio placenta separation placenta can lead to the significant maternal and bleeding and coagulopathy. Treatment is stabilization of the maternal status and delivery if it is required, it has to be done. And inter or postpartum hemorrhage, this is also nowadays less common, but it can occur. That can also cause the volume depletion and acute kidney injury during pregnancy. So during or after the delivery, usually 48 hours, there may be severe hemorrhage, intra-abdominal bleeding during or after the delivery. Most common reason is the uterine atony, that is atonic uterus. Sometimes it has to be taken out. Failure of the uterus to contract. Other reasons include the retained placenta, genital tract laceration, coagulopathy, placenta accreta, that it is so much deeply involved, we have to take out the uterus also. So these are the all pre-renal, that means volume depletion causes of the acute kidney injury during the pregnancy. So you see the patient at which trimester, find out the cause and treat accordingly. The next, the most common and redundant complication which land in our CCU is the thrombotic thrombocytopenic porphyria or hemolytic uremic syndrome. So TTP, commonly short term, and the HUS, hemolytic uremic syndrome, are both characterized by the presence of the microthrombi. This is a small thrombi that are deposited. The shower of thrombi are generated and deposited to all the small vessels and the structures. Fibrins and or platelets in multiple organ system, particularly the kidney and the brain, are the common target. Presenting features include the thrombocytopenia. Definitely will give a very low platelet count with microangiopathic hemolytic anemia without another apparent cause of and in many cases neurologic and or renal abnormalities with them, because kidney and the brain are the two target organs where microthrombi are deposited. Pregnancy may trigger the either TTP or HUS. Pregnancy itself trigger the TTP and all the late, and the most importantly TTP, that is the thrombotic thrombocytopenic porphyria, occur in the near about delivery, and the hemolytic uremic syndrome mostly occur after the delivery. That means postpartum period. Although the atypical hemolytic uremic syndrome, there are some variant, they can occur just before the delivery also. TTP is caused by the acquired or constitutional deficiency ADAMTS 30, a von Willebrand factor processing protein. This is the major culprit now, this von Willebrand ADAMTS 30. They can cause the sudden absorption, and how this ADAMTS 13 deficiency start, nobody knows, because some are genetic factor. Pregnancy itself can stimulate the deficiency of the ADAMTS 13, and it is mostly occur in the late trimester of the pregnancy. Pregnancy has shown to be induce the onset of the or relapse of the ADAMTS 13 deficiency related TTP. Patients who develop earlier small thrombi in any pregnancy, if she conceives in the next time, patient is surely going to develop the TTP, because that was an induction and that sensitized, and the subsequent pregnancy causes further flare up of the deficiency of the ADAMTS 13. The TTP associated ADAMTS 13 deficiency occurs predominantly in the second and third trimester. So it is not the problem of the early pregnancy, near about the delivery. Acute kidney injury may occur in the either pregnancy associated TTP or HUS. So TTP or HUS that initially occur in non-pregnant women may relapse during a subsequent pregnancy, and recurrent TTP or HUS may undergo during successive pregnancy, just as I was talking. The diagnosis is generally made by clinical features. If thrombocytopenia and hemolysis resolve but AKI persists, a kidney biopsy may help to define the etiology and the prognosis for the recovery of the renal function. So what you can diagnose, the kidney biopsy is the only way to diagnose the where is the thrombi. It is in the small vessel or in the big vessel, or what kind of thrombi is there. The kidney biopsy will definitely give you the, you cannot take the brain biopsy, the only accessible organ is the kidney, you do the kidney biopsy. Another variant of the acute kidney injury during pregnancy is the acute fatty liver of pregnancy. This is a very dreaded complication. Acute fatty liver is a rare complication of pregnancy that is associated with the acute kidney injury up to 60% of the cases. The chance of the acute kidney injury is very high in AFL. Patient present in the third trimester with clinical signs consistent with the preeclampsia, but also these are the features that should fit with the acute fatty liver of pregnancy: hypoglycemia, hypoproteinemia, liver function test abnormalities with hyperbilirubinemia, and a prolonged partial thermoplastic time. These factors must be present to diagnose the acute fatty liver of pregnancy. See, these are the I will conclude when I conclude I will guide how will you approach, because all they may be seen. When you see the patient not by singly, there may be symptoms of many. There may be some liver involvement, there may be some systemic involvement, but you have to diagnose in which patient you are dealing. Are you dealing with the preeclampsia, severe preeclampsia, HELLP syndrome, or acute fatty liver of pregnancy, or TTP, or HUS? Which variant you are actually, then your progress will be or approach should be according. The diagnosis should be suspected based on the clinical features. Which clinical features? That means the patient should be hypoglycemic. This is the only condition you will get the hypoglycemia, and the APTT will be higher. And you will not get the too much platelet count low. So platelet count will be really normal. So this is the guide. This is the point you should remember before diagnosis the acute fatty liver of pregnancy. The diagnosis should be suspected based on the clinical features. Therapy consists of the treatment of the disseminated intravascular coagulation. And this acute fatty liver of pregnancy occurs just before the delivery. So if you consider the 40 weeks of the gestational period, it occurs around 38 weeks to 40 weeks in this period. Whereas TTP can occur much earlier to the this gestational period, and HUS mostly occur after the delivery of the baby. The laboratory abnormalities frequently begin to improve within 1 or 2 days after the delivery. So you take out the baby, the laboratory parameter will rapidly improve. Another variant is the acute cortical necrosis. You know there is a hemodynamic changes in the kidney and the hypothalamus. The vascularity increases manifold. So there is an oxygen demand is also increases. If there is a sudden drop of the blood pressure during the delivery, whatever may be the reason, there may be less fluid replacement, or there may be some hemorrhage, that causes drop of the blood pressure and oxygen supply to the renal cortex and the posterior pituitary gland. That causes apoplexy. That is apoplexy of these two organs. Which is one thing is very commonly known to us. If there is an apoplexy, the posterior pituitary may not be revealed immediately, and over the long time present as the Sehan syndrome. And the same thing happened with the renal cortex. There is an apoplexy of the renal cortex, and the 85% of the glomeruli located in the renal cortex that may damage, and patient will be dialysis dependent. The important cause, how will you diagnose? There are 3 criteria. I will come to that to diagnosis of the acute cortical necrosis. To differentiate the acute tubular necrosis, because acute tubular necrosis is reversible. Mostly you can return back the patient to the normal life, but acute cortical necrosis, that is a knockout of the glomeruli. Patient will be dialysis dependent from the very beginning, and you have to prepare for the long-term renal replacement therapy like dialysis or renal transplantation. Important cause of the acute kidney injury associated with the catastrophic obstetric emergencies such as the placental absorption with massive hemorrhage or amniotic fluid. This is the sudden drop of the blood pressure. These are the conditions which can provoke the sudden drop of the blood pressure. Renal cortical necrosis is now generally considered quite rare in developed countries. It is virtually negligible in developed countries. However, and it is responsible for 1 to 2% of the all causes of the acute kidney injury. Even I have seen in here some acute cortical necrosis also. Renal cortical necrosis may still be an important clinical problem in parts of the world where obstetric hemorrhage occur remote from the hospital setting and is that difficult to manage. You don't know in the obstetric management which patient will be atonic uterus. You don't know. There is no preclinical idea. Patient goes on hemorrhaging. The blood is mostly, none of the obstetricians keep blood in hand while going to the obstetrical maneuver. So there is a loss of the blood. There is a chance of the acute kidney injury. Both primary DIC and the severe renal ischemia likely cause and cortical necrosis. So when endothelial injury occurs, the local release of the nitric oxide which minimize the degree of the thrombus formation by diminishing the platelet aggregation. So triad, what I was talking, the triad of the acute cortical necrosis is the oliguria or anuria. Oliguria means if the daily urine output less than 400 ml. as of today now, you can consider the plus minus 100, that is 500 ml. Anuria means if there is an urine output in 12 hours, only 100 ml, right? So this is oliguria or anuria, number one. Number two, gross hematuria. That means you will get the frank blood in that. That means more than 100 RPC per hyperfill, and the flank pain. This is a triad of acute cortical necrosis. Whenever you get a patient, post-obstetrical patient with this triad, you should only think of acute cortical necrosis, and you should not delay to start with the renal replacement therapy and non-operation. You don't have to think other causes of the acute kidney injury during pregnancy. So diagnosis can usually be established by ultrasonography or computed tomography. Computed is not required. Simple ultrasonography will help to diagnose the condition. What happens? You will see the cortical echogenicity is lost, and over long time cortical thickness will be lost. Normal cortical thickness is 1 to 1.5 centimeter. After 2 to 1 month or 6 months, you will see the cortical thickness is less than 1 centimeter, and cortical density is less. That means it is looks black. So if you do an USG, often patient with acute kidney injury, suspecting acute kidney cortical necrosis, just do an USG and note the color of the USG finding in USG. If the cortex is black, then it is basically acute cortical necrosis, together with this triad of this finding. No specific therapy has been shown to be effective in disorder. Many patients require dialysis, for about 20 to 40% patient partial recovery with creatinine clearance that stabilizes between 50 to. Some patients, you know, the 15% glomeruli located in the glomerulus, there may be partial recovery. Patient recover partially, creatinine 2, 3, like this range. Patient may not require dialysis, but it will be chronic kidney disease eventually in the dialysis. The acute pyelonephritis in pregnancy that can also cause the acute kidney injury during the pregnancy. This is also increases because of the reflux uropathy is there. Although the kidney function is generally well maintained during the episode of the acute pyelonephritis, pregnant women are at increased risk of the acute kidney injury. And once the acute pyelonephritis is there, you have to give the IV antibiotics for at least 2 weeks, because the antibiotic don't reach in therapeutic concentration to the perinephric space. Whatever you give orally or any other route, it will not reach to the therapeutic concentration. So acute pyelonephritis may develop at any time during the pregnancy, but is more likely to occur after the second half of the pregnancy. That means after 20 weeks of the pregnancy. The diagnosis is generally made by the clinical features, urine analysis and urine culture. Just do the urine culture. If the patient complains of flank pain, do the non-contrast CT. That will demonstrate the fat stranding around the pelvic system together with the collection, that is the acute pyelonephritis. Kidney biopsy is generally not performed. We don't do in any febrile condition in patient with acute kidney injury and characteristic feature of the pyelonephritis. Now, urinary tract infection that can also cause the acute kidney injury during the pregnancy also, because of the relaxation of the ureteral smooth muscle and the pressure on the ureters by the gravity uterus result in mild to moderate dilatation of the collecting system. Because all obstetrician, you know, there is some epistasis and there is obstructive uropathy features is there because of the compression of the gravity uterus. The functional hydronephrosis, which tend to be more prominent on the right side, is detectable by the ultrasonography, but it is not usually associated with the renal dysfunction, and these obstruction doesn't require any therapy. After the delivery, it will resolve on its own. If there is complete obstruction and anuria, you just put the digestate, it will correct the condition. Obstruction of the ureter by the uterus is sufficient to cause the renal failure. If the severe obstruction, that causes the both of the kidney obstruction and the post-obstructive acute kidney injury during pregnancy. The diagnosis can be established in some cases by normalization of the renal function in the lateral recumbent position, or you ask the mother to lie down on the left lateral position. That will relieve most of the pressure. That will avoid the direct compression to the ureters. If acute kidney injury resolved with the relief of the obstruction, that this may be achieved by the insertion of a uterine stent or delivery of the fetus. The NSAID, that is the most misused or overused medicine after the delivery. That is also an important cause of the acute kidney injury. The NSAIDs are routinely used for the postpartum analgesia, particularly after the cesarean section. Nowadays, the normal delivery is obsolete, and to relieve the anxiety of the pain, we give the analgesic. But mind it, please don't use the combination analgesic. Although the uncommon among such patients who receive the NSAIDs, acute kidney injury may develop if there are predisposing conditions such as the volume depletion or preeclampsia. These patients are more prone to develop the acute kidney injury than the normal patient. That means all patients, those are volume depleted, not taking, the before cesarean section, you don't allow anything to take by mouth. There isn't considered the volume depletion. And on the top of that, if you give the combination analgesic, there is a more chance of develop the acute kidney injury. Or what happened after the delivery, you don't allow anything to take by mouth. There is a prolonged dehydration. If you give analgesia to relieve the pain after cesarean section, they can also predispose to the acute kidney. So these are the basic practical things you should remember. Hydration is the mainstay of the therapy, whatever methods are passed. So this is not very good to see. Is it visible? Skip it. I will come to the one time. So how will you diagnose? The approach to the differential diagnosis, that means the major problem that I have discussed. Identification of the cause of the acute kidney injury is important in order to administer appropriate therapy. So you see a patient, you don't know what kind of patient is there. You have to first diagnose what kind of patient you are dealing. You are not dealing all the disease at a time. Okay. So you have to diagnose what are the problem of this patient you are dealing. The initial diagnosis approach to patient with acute kidney injury during pregnancy is similar during all stages of pregnancy. So it is important to exclude the causes of the acute kidney injury that are unrelated to the pregnancy. There are some factors that may be not related to the pregnancy, like dehydration or some other factor, like glomerulonephritis, that because it flare up during pregnancy, or acute tubular necrosis due to toxin, drugs, or stress. Medical history prior to the lab values are important. You should take the history properly. A history of systemic lupus erythematosus. You know the lupus is the disease of the childbearing age group. They may flare up during the pregnancy and they may cause the acute kidney injury. The history of systemic lupus erythematosus or laboratory evidence of the proteinuria or a reduced eGFR prior to the pregnancy may suggest worsening of the underlying glomerular disease that is unrelated to the pregnancy. Medical history may also suggest cause of the prerenal AKI to acute cortical necrosis. It is very easy to diagnose. So in addition to the careful history, physical examination and the medical review, you have to review. The pregnancy is a long-term journey, almost 9 or 10 months journey is there. So you have just get a time and to review the previous history if it is there. That will help you to come to your pinpoint your diagnosis. Following the test are the perform. So these are the basic tests you should perform whenever you get the acute kidney injury during the pregnancy. Dipstick urine analysis or microscopic analysis of the sediment. See how much proteinuria is there. Quantification of the proteinuria by 24-hour if it is possible and feasible. If it is not, you just send the spot urine sample for acute kidney albumin-creatinine ratio. Do urine culture, you are dealing the urinary tract infection or the sepsis procedure or not. Hemoglobin level and the platelet count definitely should be done, and the peripheral smear, don't forget to mention peripheral smear of the blood whenever you are dealing the acute kidney injury pregnancy to see any schizontosites present, that means crenated RBC are present or not. That will guide whether you are dealing with the HS or TTP or not. That means that will help to clinch the diagnosis of the microangiopathic hemolytic anemia and thrombocytopenia. The total direct and indirect bilirubin concentration, as we commonly do the LFT, that should be done. Haptoglobin level, that is important, and LDH to diagnose whether there is an ongoing hemolysis or not. That will give you the guidance. And CRP level to exclude, there may be highest degree of infection that involve the multi-organ. In that case, you will get the elevated liver enzyme. To do the CRP, that will also help you to differentiate the diagnosis. ASTLT test, that is important for diagnosis of acute liver during the pregnancy. And the renal ultrasound, just to diagnose whether you are dealing with any acute cortical necrosis or if there is any obstruction. It may so happen earlier because of the negligence, the ureter are subsequently, it is blocked. I have seen few patients, they are done OT outside the obstetrics, the ureter accidentally it is tied. So everything is normal, nothing is coming out, patient is on catheter because the source of this road is blocked. So yeah, simple USG will help you to guide you. Just remove it and everything will be alright. And in that cases you may get the urinary serum, urea creatinine 200 tail like that. But you have to do the USG if it is possible, portable. So differential diagnosis of the intrusive renal disease in reproductive age group. These are the common renal disease that can occur during the reproductive age with all their flare up during the pregnancy. I am not going in details. Funticular necrosis, vasculitis, acute glomerulonephritis, and acute interstitial nephritis. Most importantly, I should discuss the last one, that is acute interstitial nephritis. This is, you are using a lot of drugs during the pregnancy and after the cesarean section. So you don't know which drug causes the acute interstitial nephritis. All drug can cause the acute interstitial nephritis. And you are getting the good amount of urine that you are, when going to the round, patient is saying nausea, vomiting, unable to do anything by mouth. And you will do the investigation, the serum urea creatinine is very high, but patient is producing good amount of urine. So what is this? This is nothing but acute interstitial nephritis, and mostly drug induced. So in acute interstitial nephritis, the urine output will be normal, even more than the normal, because of the concentration defect of the kidney that is occurred in the interstitium. The glomerulus is normal. So just check out the drug list and stop the drug offending that will help. The most commonly drugs that we give during the pregnancy, like drug like the penicillins, cephalosporins, sapronamides, rifampicin, ciprofloxacin, NSAID, thiazide diuretics. NSAID is a notorious drug. It can cause everything. And furosemide, which is commonly given if there is no urine or less urine, and cimetidine, which is not now being routinely used, phenytoin, allopurinol, autoimmune disorder, lupus, that may. These are the common drugs which are mostly used and peripreterm period that causes the acute interstitial nephritis. So simply by basic investigation, gestational age, you can diagnose whether you are dealing some acute glomerulonephritis flare-up or preeclampsia. These are the some important point. The most important point is the proteinuria. You see, the preeclampsia proteinuria more than 300, but glomerular disease it should be more proteinuria. Just routine investigation will help you, and you do the C3, C4, ANA. C3 complement 3, complement 4, and antineutrophil factor that will guide. All these are elevated in glomerular disease, but it is not in case of preeclampsia. So again, I am back to my original slide, the timing of AKI. Yes, septic abortion, abruptio placentae, these are major problems in the near about the pregnancy, and the TMA and TTP, HUS are the major culprit in that disease. So differential diagnosis, if there is a third trimester preeclampsia, preeclampsia or HELLP usually occur in the third trimester, and acute fatty liver close to the term, as I was talking, thrombotic median is 23 weeks, sorry, because it takes after 20 weeks to the delivery. The TTP can occur any time. HUS often after the postpartum. This is the timing of the onset of the diseases, major diseases, preeclampsia, HELLP syndrome, AFL, and the TTP and HUS. So primary unique clinical manifestation, if you see the HUS, proteinuria will be there. In HUS, in preeclampsia and HELLP. Acute fatty liver, there is a malaise. In thrombotic neurologic, this is the only condition where neurologic features will be there. Patient will suddenly go in convulsion or irregular talking or disorientation. This is among all these 4 or 5 conditions, TTP is the only condition that thrombi are directly deposit the brain and causes the neurological dysfunction. We will not get the neurological dysfunction in all other conditions. Parburia, yes, parburia is only present TTP. Yes, these are two diagnostic point of the TTP. Since it occurred from median age is 23 weeks to the term, so presence of these two important clinical features will guide you. That means presence of parburia and the neurological history that will clinch you the thinking towards the TTP. So fever is present also the TTP, not for the other conditions. Hemolysis, yes, present both in case of TTP and HUS because of the hemolysis. And coagulation studies, if it is coagulation as a just AFL, the acute fatty liver of pregnancy, you will get the higher APTT level, not in the other condition. And hypoglycemia also is a stigmata of the acute fatty liver of pregnancy. And other laboratory abnormalities, that is Adam TS 30 deficiency, which is not practically possible nowadays in our country as of today, and not included. And primary treatment, preeclampsia, eclampsia, it is a delivery, acute fatty liver, it is the delivery, everything will be. Last toothpaste is the plasmapheresis as of today. And nowadays some drugs are coming out to treat the ADAMTS deficiency, and ADAMTS, this biosimilar product are coming to manage the deficiency ADAMTS 30, to counter the TTP and UHS. It will come shortly, and one of the Indian companies coming with the collaboration of some international companies. So disease-specific treatment of acute kidney injury in pregnancy. If you treat the hyperemesis gravidarum, it is the hydration. Okay. In the same time, we have also urinary tract infection. Identify the cause and treat the antibiotic that will resolve. Preeclampsia help acute fatty liver pregnancy delivery. The problem is resolved. TTP, plasma exchange, and rituximab. But pregnancy, rituximab is contraindicated. You should not give the rituximab during pregnancy. You should give in non-pregnant lady. Atypical hemolytic uremic syndrome, eculizumab. Yes, again it is very costly, not available properly. You can try if it is available, but plasma exchange is the mainstay of the therapy. Obstetric, you will do the USG, give the stent, put the stent, or nephrostomy, that means the separate way to take out the embryo. Placental absorption or hemorrhage, control bleeding, and delivery if it is not controlled. And glomerulonephritis, give the previous dose of the steroid or immunosuppressive drug that was taking prior patient before the conception. So we are very much fond of and get I refer the what antibiotic you should give. Antibiotics are basically during the acute kidney injury in pregnancy. Some are oral, some are IV. If patient can take, you always give the oral antibiotic, and if it is not, then it is IV. Again, if there is a edema, oral antibiotic bioavailability is very poor. But if there is edema, then edema is not only to the dependent part, at the same time to the gut also. So there will be erratic absorption. There will be less therapeutic response. So preferably during acute phase you give to the IV. So if there is you can use a nitrofurantoin, the most popular drug. You can give 100 milligram twice daily. It can be given 5 to 7 days. But mind it, you should not give this insulin deficiency patient and the third trimester of pregnancy. It should safely be given after the second trimester of pregnancy. And this is the level of evidence. Amoxicillin, another drug, and the 500 milligram 8 hourly to the 875 milligram every 12 hourly can be given. 3 to 7 days therapy. But it is not too much effective gram-negative bacteria. Cephalexin, another oral drug that you can use, 500 milligram every 6 hourly that can be given. It should be given 3 to 7 days. And these are the safe in acute kidney injury in pregnancy. Cefodoxime, orally it is 100 milligram every 12 hourly, 3 to 7 days can be given. That is safe, can be given during the acute kidney injury in pregnancy. Coming to the IV drugs that can be used in acute kidney injury during pregnancy. The ceftriaxone. Nowadays we are not using ceftriaxone, but international guidelines says it is very good and effective drug. It can be given 1 gram every 24 hourly. That means 1 gram is sufficient. Or you can give the divided doses 500 milligram 12 hourly. It should be given 7 to 14 days. Cefepime, another drug that will be given every 1 gram every 12 hourly, 7 to 14 days. Cover the serominas, this is a beneficial effect. Azithromycin, it can be given 1 gram every 8 hourly, give 7 to 14 days in setting of the beta-lactam allergy, those who are not tolerant to beta-lactam. Piperacillin tazobactam, this is a very good drug, and this combination is not available. Auto combination available 4.5 gram or 2.25 gram, but the ideal dose 3.375 gram. And it's very good drug for any kind of sepsis during the pregnancy with acute kidney injury. It can be given 3.375 gram every 6 hourly. And the meropenem, yes, this is the drug which you are using most commonly. It can be given 1 gram every 8 hours. Do we give? No. We give the subtherapeutic dose, 500 milligram every 8 hours. But the dose is in renal acute kidney injury 1 gram every 8 hours.
1 gram TDS. 1 gram TDS.
So it can be given 7 to 14 days, limited data, internationally limited data. We don't have any antibacterial protocol here. So we can use this meropenem or better say piperacillin tazobactam in severe infection during pregnancy. So management of AKI during pregnancy, management principle, pregnancy associated AKI follows. Treat the underlying cause. To first identify if it is possible. Prevent progression of the renal damage. That means it should be assured that it is not going further damage. Maintain supportive measures and consider the maternal health as a primary while optimizing the fetal well-being. Okay, after the delivery, fetus is kept somewhere else. The baby, I should not say the fetus, and the mother is in your hand. A multidisciplinary approach is required to give the better quality of treatment that includes all the medical specialties or subspecialties. General measure to treat the pregnancy-related acute kidney injury include identification of the underlying source of the injury, volume resuscitation, prevention of the further injury, timely initiation of the renal intervention. You should not delay. As urine is producing, that means whatever urine is producing may be below normal at that peripartum period. So you should not wait for delay of the renal replacement therapy. Application of the acute kidney injury can be treated as a non-pregnant patient, that is hyperkalemia. In most circumstances can be treated with that is potassium binding agents, metabolic acidosis with alkali therapy, that is sodium, volume overload with the loop diuretics, and anemia with the blood transfusion. These are the supportive therapy. But how long you should give the diuretics? If the patient don't produce any urine, come to you with acute kidney injury during pregnancy, you first replace the volume, ensure that patient is adequately hydrated. How will you check? By checking the IVC diameter. Okay? If the patient is ventilated and you put on the central venous line, it will give the fall impression. You just see the collapsing of the IVC. If it is adequately dilated, diameter parameter is there, then give the diuretic only once. In which route? IV or oral, equally effective. Since patient cannot take the orally, you give the IV route. Maximum therapeutic dose is 200 to 400 milligram of furosemide. You give, if patient produce urine, okay, continue. If it is not, don't repeat it. You put the patient to the dialysis. Because repeated IV diuretic can cause the further interstitial nephritis and further worsening the renal function. If these measures prove unsuccessful or if renal injury progresses, initiation of the renal replacement therapy will be necessary. Steroid and immunosuppressive therapy may be warned if the biopsy proven of the glomerulus, if the earlier case was some glomerulonephritis. For the diagnosis of the severe preeclampsia, HELLP and SAFE syndrome and acute fatty liver of pregnancy, prompt delivery is a rule. Treatment of the TMA including TTP and the atypical HUS requires the plasmapheresis and administration of eculizumab. If it is available, if it is not, you do the plasmapheresis only. And around this 30, if it is available, you should give. If it is available. I hope in the end of this year, the ADAMTS 13, that is biosimilar ADAMTS 13 will be available. Dr. Reddy is coming with this portfolio. But the special consideration for dialysis in the pregnancy, that is not those who are interested in dialysis, they can itself. Hemodynamics, what we should achieve, careful attention to the avoiding the hypotension. So during dialysis, you should not put the patient for hypotension. That can cause the ischemic renal damage. So fluid fluctuation, too much fluctuation will not be there. You should not give too much fluid, 3 liter, 4 liter by all medication. That can further worsen because that causes edema. The drug will not reach to the target site and the recovery will be delayed. The volume changes in the pregnancy. Hypertension also should be treated in severe cases. Longer duration and higher frequency of the dialysis recovery. Longer durations means what we commonly do is the 4-hour dialysis for conventional. But in these patients, because the low BP, you have to give the prolonged therapy. So that is effective clearance and the without much fluctuation of the hemodynamics. That is the concept of the slave that is mostly used. Blood and urea nitrogen, and it should be kept as below as possible. That in burn should be around 50 milligram per DL. And maternal weight, what it should be, and the maternal daily weight gain should not be more than 1 to 1.2 kg. For the first trimester, if you do the dialysis, and 0.3 to 0.5 kg per week in the second and the third trimester, if you do the dialysis. And the serum bicarbonate, it is low during pregnancy. Remember the physiologic metabolic acidosis, compensatory respiratory approach is there. In pregnancy, bicarbonate normally is low, 4 to 5 milliequivalent, so it should be replaced. And contraction, scrutinize closely for the preterm contraction and the preterm labor. Vitamins and the folate and other supplementation, do you need to use? Yes, required in pregnancy and removed by dialysis, because water soluble vitamins are removed during the dialysis. You have to replace it by after the dialysis. Water soluble vitamin has to be replaced, and you should give the iron because that is an important for the hemoglobin production, and the erythropoietin that also to be given. Anemia and erythropoietin level, if exogenous erythropoietin is needed, therapeutic dosing generally in a higher in the pregnancy. So a higher dose of the erythropoietin may be given. But indiscriminate use of calcium should be avoided. That is a common practice that should not be done. So this is my take-home message after this exhaustive discussion. So AKI in pregnancy, acute kidney injury in pregnancy, that is called the PRAKI, the new term, is poorly defined as physiologic change in pregnancy that lead to the significant increase in glomerular filtration rate and 50% fall of serum creatinine during the pregnancy, making it difficult, unsuitable to fit it in the standard AKI definition. Standard AKI definitions means the Raphael criteria and Akin criteria that is not applicable during the diagnosis of the acute kidney injury in pregnancy. In PRAKI has decreased globally because of the improved obstetric care and better healthcare access. However, in developing countries, puerperal sepsis, hemorrhage and severe preeclampsia remain a cause of poor maternal and fetal outcome. In developed world, pregnancy at a higher age exposes the mother to AKI due to the many comorbid factors like hypertension, diabetes, obesity and the chronic kidney disease that I was just discussing. The compounding microangiopathic associated causes of PRAKI, atypical hemolytic uremic syndrome, thrombocytopenic purpura and antiphospholipid antibody related syndromes are rare but difficult to differentiate from the relatively common causes like preeclampsia, HALP and lupus nephritis during the pregnancy. The clinical clue-based high suspicion index and differential diagnosis, a battery of the test may be available to reach the right diagnosis early. Early global detected therapy with improved both fetal and maternal outcome. Puerperal infection and the hemorrhage by initiated cascade of multifactorial acute kidney injury and many remain one of the most important preventable cause of the PRAKI. And interdisciplinary collaborative approach for sepsis preventive and early diagnosis initiative to improve the outcome. And management of the pregnancy-related acute kidney injury include treatment of the underlying cause, preserving the kidney function and providing the supportive care for those who need dialysis and intensive care unit support. Thank you.